This is a case of a 19-year-old female with no previous medical history presented to her PCP with abdominal pain and difficulty eating. She's found on imaging to have a 16 centimeter hemangioma. The lesion had a large feeding vessel that was embolized preoperatively. This is a representative image of our port placement with 4 ports. We began the operation by taking down the falciform ligament up to the IVC and the confluence of the hepatic veins, as well as taking down the triangular ligaments on the left. Here you can see the momentum was quite adhesed to the lesion, requiring some dissection and use of the vessel sealer to take some of the smaller vessels. Removing the omentum and mobilizing the mass was crucial to expose the normal anatomy. The gallbladder was eventually visualized, as you can see here, but it was obstructing our view of the porta hepatis, and it had to be taken, which was discussed with the patient preoperatively. Once the cholecystectomy was performed, there was a bridge of parenchyma that was taken with a vessel sealer. This allowed adequate mobilization of the mass to expose the porta hepatis and the major feeding vessel, which was the entire left hepatic artery. This was bulldogged, and using ICG we were able to verify that this was the correct vessel, and it was doubly clipped and ligated. Following the ligation of the feeding vessel, we began the parenchymal transection using the vessel sealer. The vessel sealer was utilized for the more superficial portions of the parenchyma, and the parenchyma was thinned out for both sides. Once the tissue was adequately transected, the stapler was applied, and this is much more helpful in the deeper layers for controlling the bile ducts and the left hepatic vein. Again, due to the size of this lesion, we had to go from both sides in order to adequately visualize where the stapler was going and to understand completely what structures are being transected. Finally, the mass was completely removed from the parenchyma, and blood flow was checked with ICG and found to be quite well perfused. Hemostasis was achieved with electrocautery, and the hemostatic powder was applied, and the mass was placed into an endo-catch bag and removed by morcellation. Consult time 200 minutes, EBL 300 cc's. Thank you for listening.